Bismillahirrahmanirrahim. Today, our topic for this presentation will be to complete MR Defecography Part 2. I am Dr. Muhammad Tarat, Assistant Professor of Radiology, Cairo University. This is one of the teaching session for Easy Radiology Approach era. As we discussed before, MR Defecography consists of static MRI images are used to visualize pelvic floor anatomy and effects of the supporting structures, while the dynamic MR image are used to visualize pelvic organ mobility, pelvic floor weakness, and pelvic organ prolapse. How to report these cases? MR defecography. It is very simple and it's not complicated. Once you can classify the points that you need to report, it will be very easy. So starting with the anterior compartment, you should check if there is any possibility of cystocele, urethral orientation hyperlaxity, urinary incontinence. In the middle compartment, uterine cervix and vaginal vault. We are using vaginal vault in case of hysterectomy. Otherwise, we are using the uterine cervix is our landmark. Also, we should see or comment for the paravaginal fascia or any defect in the paravaginal fascia, and also rectovaginal fascia. Regarding the posterior compartment, we should focus on the anorectal junction. We are using H and M lines. Also check if there is any possibility of rectoceles or not. Check also and don't forget if there is any possibility of intussusception, either rectal or anal or extra-anal. We will discuss all of these points in details. Starting with the static MR image, we have multiplanar T2 images, as we discussed in the first part. We are using the axial plane, axial T2 plane. As you see here, this is the axial plane. We should focus, this is the pubic muscle. We should see the pubic muscle. It is symmetrical, normal wall thickness. Also, we should see the vagina. This is the vagina. It takes H-shape configuration or butterfly configuration. This is normal. And once you have this preserved normal H-shaped configuration, so we don't have any paravaginal fascia or something abnormal in this supporting structure for the vagina. Also, the morphology of the vagina is smooth and symmetrical. This is the urethra. In this static image, also we should measure the levator hiatus length, anteroposterior diameter. I prefer to measure this one in the sagittal plane. Also, we should measure the width of the levator hiatus. This one between the maximum diameter between the pubic slings. Also, we see or we should check the coronal plane. As you see here, the coronal plane, the levator inni muscle symmetrical in shape. Also, it is preserving its normal thickness and normal configuration. Its normal configuration, the normal configuration of the levator inni muscle is preserving its convexity, upward convexity. This is the normal configuration of the levator inni muscles. Once you have any levator muscle atrophy or wasting, this one could be horizontal in configuration or sometimes concave. We are using also the sagittal plane as a reference for the functional image. So it's very important to have axial, coronal, and sagittal planes. How to assess the static and dynamic MR image? We are using different angles and lines, and sometimes we have some points related to dysnergic defecation. So regarding the angles, the most important angle is the anorectal angle. The second is levator plate angle, and the third is iliococcygeal angles. We have also lines, pelvic floor descent. We should comment on PCL or pubococcygeal line or H and M line. These angles and these lines should be assessed during rest and during straining. Regarding the dysnergic defecation, this is a functional obstruction. We are using some parameters regarding the degree of rectal emptying and also the anal diameter, and again the anorectal angle is used to assess any functional obstruction. Regarding the angles, as we discussed before, the anorectal angle is the most important one. This angle between line drawn within the anal canal and line drawn along the posterior aspect of the rectum. This is, as you see, 113. Should be measured in the resting and during straining. Levator plate angle, this one was drawn or was measured between the pubococcygeal angle and the line going down to the levator plate. Levator plate, this one is a fusion between the iliococcygeal muscles in the midline. Also, we have iliococcygeal angle, this one between the horizontal line and the line drawn along the iliococcygeal muscle. Iliococcygeal muscle is a part of the levator ani muscle, the most posterior part of the levator ani muscle. Those angles are less important than this one. This one is the most important, and this one that I am depending on my reporting on this angle. Again, I remind you, as we discussed in the first part, the anorectal angle during rest here. During squeezing, there is a contraction of the puborectalis muscle, so this angle will be exaggerated and will be more acute. Once the patient starts to defecate, the puborectalis muscle start to relax and the anorectal angle starts to be more obtuse. Regarding the lines, we have pubococcygeal line, and this one should be drawn between the inferior aspect of the symphysis pubis to the last coccygeal joint, as you see here. This one should be drawn during rest and during straining. This is one of the most important lines. Also, we need to measure what we call the H line, and this H line connecting the puborectalis muscle here to the inferior aspect of symphysis pubis. To simplify this point, this is the most important point. This one is the junction between the rectum and the anus, an anal canal. This one, once the rectum start to tapers and ends, this is the junction between the rectum and the anal canal, and you can scroll the sagittal image to detect the puborectalis muscle. This is the site of the puborectalis muscle. So this one is called H line, and H line is considered as the levator hiatus. This one in the normal measurements should not exceed 5 centimeters. From this point also, we should draw a perpendicular line on the PCL line to make another line, what we call the M line. M line, this is the main reference for the pelvic organ descent for the posterior compartment. This one measures 1 centimeter, and those are normal measurements. So again, our normal dimensions regarding the angles: normal anorectal angle between 108 and 127. Regarding or during the squeezing, this angle should be reduced within 15 or 20 degrees, while during straining and defecation or evacuation, this angle will be increased at least between 15 and 20 degrees. So the same degrees, but this one during the squeezing, the angle will be decreased. During straining, the angle will be increased. For the lines during rest, H line, as we said before, should be less than 5 centimeter or equal or less than 5 centimeter. M line also should be equal or less than 1 centimeter. During straining, these lines will be slightly increased. It should be accepted if H line is less than 6 centimeter and M line less than 2 centimeter during straining. So if we have any abnormalities, we should grade this abnormality or the degree of prolapse of the posterior compartment. Either we have mild degree, moderate degree, or severe degree. If we have mild degree, the M line, if the M line is between 2 to 4 centimeter during straining, I'm talking now during straining. If the M line between 2 and 4 centimeter, it will be mild degree. H line should be between 6 and 8 centimeter. Moderate degree from M line from 4 to 6, and H line from 8 to 10. And severe degree, M line more than 6 centimeter and H line more than 10 centimeter. To simplify the condition, as you know that the M line should be less than 2 centimeter, we are applying the rule of 2. What does it mean? The M line is the mild degree between 2 to 4, the second from 4 to 6, then more than 6 centimeters. So we are applying 2 centimeters. difference, 2 centimeter here, 2 centimeter here, then above. So we are applying the rule of 2. Also the H line, we are applying the rule of 2. Grading of the abnormality of the different compartments, as we said before, the H and M line, rule of 2. Rectocele, we are using a rule of 2. We will discuss this one later on. Uterine, cervix, and vaginal vault and enterocele, all are abnormal once we have any of these structures below the PCL, and we are applying a rule of 3. Cystocele, it is abnormal if we have the bladder neck more than 1 centimeter descent below the pubic line. We are applying also rule of 3. So we are applying rule of 3 for all except the rectocele and the H and M lines. If we see here, the urethra is vertical. This is a normal configuration. Once the patient starts to strain, the urethra starts to take horizontal orientation, and this one of the causes to make that make the patient has difficulty in urination. So let us measure our H and M lines during resting. Here, during resting, the H line is 6 centimeter. It is above the normal. And also the M line 2.2 above the normal. This one before straining. Once we start to strain, the bladder neck start to descend, and also we have significant prolapse of the rectum. As we said here, the urethra is vertical, started to be more horizontal. If we measure here during maximum straining, the H line became around 9 centimeter and the M line became 5.7 centimeter. So we have here moderate degree of posterior compartment involvement or posterior compartment prolapse. We have also cystocele measuring 2.1 below the pubic line. So this one is considered as a first degree or mild degree of cystocele. Again, in this case, we ask the patient to strain again and again. Just before defecation, we start to measure again, because this is dynamic series or dynamic image. We start to measure again as a maximum strength, maximum point of straining. Just before the defecation, we measured the M line. We found that it is 6.6 centimeter. This is considered a severe degree of prolapse for the posterior compartment. Also, we have here the anterior bulge of the rectum. Look for this one. This is anterior rectal bulge measuring 4.1. This is called rectocele. We are measuring rectocele from the anterior part or anterior wall from the anterior wall of the rectum till the anterior rectal wall here. This one, as you know, the rectum the normal configuration will be here like this one. So we are drawing the line at the presumed site of the anterior wall and draw perpendicular line to the anterior rectal line. So this one is called rectocele, and we are applying a rule of 2. The patient start to defecate, but we have here a very amazing surprise really. Look for this one. The mucosa of the rectum starts to be invaginated inside the rectum. This invagination coming from the posterior wall of the rectum. So we have here a potential risk or possibility of intrarectal interception, and this one make difficulty in defecation also for the patient. So in conclusion, for this case, we have severe prolapse for the posterior compartment with severe anterior rectocele and possible intrarectal mucosal interception. This interception most likely mucosal interception because the entire wall is preserved. We have also mild prolapse for the anterior compartment, mild cystocele, and we have urethral hypermobility. The urethral hypermobility is documented by the orientation of the urethra. It is here horizontal instead of being vertical. I want to emphasize something important here regarding the rectal or anal intussusception. We have two types, either mucosal or full thickness. Also, we have grades, either intrarectal, intraanal, or extraanal. This one is intrarectal, this one is intraanal, and once you have a pouch extending outside the anus, so this one is extraanal. And this one is full thickness because it's taking the full thickness of the rectum. In the last case that we demonstrated before, we have mucosal intussusception. This is another case. As you've seen here, there is mild prolapse for the posterior compartment, but the surprise here is the uterus. The uterus is totally extruded outside, prolapsed outside. I think it is severe degree of prolapse. So this one is uterine prolapse. Also, we have here cystocele. I think something like severe cystocele. So we should measure the point here from the uterine tip till the pubococcygeal line and apply rule of 3. We need to highlight something very important, what we call the rectovaginal fascia or rectovaginal fascial support. Once this fascia, if there is any defect in this fascia, there will be peritoneal sac or bowel loops invaginating between the vagina and the rectal wall. And we are applying the rule of 3 also. If we have a descent more than 2 cm inferior to the pubococcygeal line, so this one needs coldoplasty. Once we have enterocele, don't say it is peritoneocele, just term or say it is enterocele, because of course enterocele means peritoneal defect and bowel loops within. If we have a peritoneal sac only, so it is peritoneocele, not enterocele. As you see here, this is a pubococcygeal line and this is large defect including the peritoneal sac. The peritoneal sac occupying a large defect, and there is herniation or descent, marked descent of the small bowel loops. This is called severe enterocele. So we are measuring this one from its tip till the pubococcygeal line and apply rule of 3. Our last point is that we need to discuss regarding the functional obstruction or dysnervification. This one is functional disorder, and this one is characterized by paradoxical contraction of the anal sphincters or puborectalis muscles. Instead of being relaxation or during normal defecation, these muscles should be relaxed, but unfortunately these muscles during the defecation start to contract instead of being relaxed. This one can lead to chronic constipation. One of the most important points that we need to focus or help us to diagnose functional obstruction, the degree of rectal emptying. During the scan, during the dynamic scan, we should ask the patient to defecate at least 3 times and assess a patient. This functional assessment should be assessed 3 times. After defecation or after 3 times of defecation, we should, by visual assessment, compare between resting and post-defecation. If we have more than 50% of the gel still present after the defecation, so this one is called rectal retention of the gel. Okay, so this one is visual assessment. If we have more than 50% still remain inside the rectum, so this one may suggest or may help us to have or to diagnose functional obstruction. We have 2 types of spastic pelvic floor syndrome or dyssynergic defecation. The first type is anal sphincter type, and the second type is puborectalis type. Anal sphincter type, that means spastic anal sphincters. The anal sphincters failed to relax during defecation, and the parameter, the most important parameter is the diameter of the anal canal during defecation. If it is below or less than 15 millimeter during defecation, this is one of the most important points that may help you to diagnose anal sphincter type of spastic pelvic floor syndrome. Puborectalis type, this one is paradoxical contraction of the puborectalis muscle. Puborectalis muscle start to contract instead of being relaxed during defecation, and this one should be diagnosed by the anorectal angle, and we will show you a very demonstrative case for this one. Look for this one. This is the resting state, and this is during defecation. What's the difference? Here the angle is 102. During defecation this angle should be increased by 15 to 20 degree. But unfortunately, you will see here the angle became more reduced during defecation, more acute, and also there is significant impression of the puborectalis muscle. This muscle should be relaxed during defecation. This one considered as puborectalis muscle dysfunction, or what we called paradoxical contraction of the puborectalis muscle, and another name is spastic puborectalis muscle. Also, as we discussed before, the anal canal should be opened more than 15 millimeter. Once we have the opening is 10 millimeter or less, something like this, we can suggest there is anal sphincter spasm. Also, we have here during the defecation, this is second type. This is the anal type of functional obstruction. This is the puborectalis type. This angle, look for the anorectal angle. It is became more acute, and also the impression of the puborectalis muscle became more exaggerated during defecation, and this one can lead to functional obstruction. Our last tips for today's session: urethral hyperlaxity. Instead of being vertical orientation for the normal urethra, the urethra can be oblique, transverse, or inferior sloping of the urethra. This one, the severe degree of urethral hyperlaxity, or what we call kinked urethra. Peritoneocele, enterocele, or uterine cervix descent can make significant compression upon the rectal segment. Sometimes, in some cases, if we have a marked enterocele or uterine cervix descent, sometimes the descent of the uterus compressing the rectum posteriorly and make more retention for the gel inside the rectum during defecation. Rectocele can be anterior or posterior, but anterior is much more common and measured as a distance from the anterior or posterior rectal wall, as we saw before. The patient can give history that finger manipulation inside the vagina helped complete evacuation from the rectocele. Sometimes the patient use this history that the patient start to manipulate her finger inside the vagina to evacuate the rectocele. Pelvic organ prolapse can be isolated, either anterior compartment, posterior compartment, or something like this. If we have triple compartment, anterior, middle, and the posterior compartments, this one we called it descending peroneal syndrome. Thank you.